Thank you so much for joining us today for our Benefits Buzz Weight Loss Tactics with Enhanced Primary Care. Before we begin, please note that this event will be recorded and we will share the recording in a follow-up email sometime early next week. I am so pleased to introduce you to Elena Gambin, Chief Strategy Officer and Chief Growth Officer here at First Stop Health. Elena, would you like to take a moment to introduce yourself?
Yeah, hi everybody. Good to be with you again. We are excited to talk today about a very, very buzzy topic in the market. And honestly, what we try and do with these sessions is react real time to some of the questions that we're getting in the market so that we can be useful to you all. And the number of conversations I've had in the last month and a half alone around GLP-1s and how we support weight loss has been pretty profound. So we wanted to focus today on that very topic. And I wanted to start off by kind of talking a little bit about the buzz that we're hearing and the concerns that our clients and our prospects and our consulting partners are sharing with us around this. So for those of you who don't know, the GLP-1 debate around how do we cover it for our employees? Do we cover it for our employees has kind of reached a head in this year because the FDA is kind of incrementally expanding its definition of how this particular drug can be prescribed. And so there are a lot of concerns that we've been hearing from our client partners. Number one is there's concerns around the long-term efficacy of a GLP-1 as a true weight loss medication outside of a relationship with a comorbid disease like diabetes. And the reason why is there is a lot of evidence that patients who stop taking GLP-1s regain the weight pretty consistently if they are not also working on addressing the sort of underlying issues associated with weight gain as it pertains to behavioral dynamics, social determinants of health, lifestyle choices, etc. So this concept of medication alone being enough is sort of up for debate. The second is around concerns around affordability. So the costs for GLP-1s, both on an individual front and on a plan front are pretty significant. And these employers that we're working with, you're having to make hard decisions when it comes to if you're going to cover it. And if you do, what are the prior authorization requirements surrounding this? So some of what we're seeing is employers will choose to cover GLP-1s only if the patient also has a diagnosis of diabetes or kidney failure. Or they might say, we're going to cover GLP-1s for anybody, but it requires a prior authorization. Or we're going to cover GLP-1s, but it requires step therapy where we have to have a patient demonstrate X, Y, and Z information as well as 6 weight loss coaching episodes. And that conversation that you're having with your consultant and that your consultants, if you are one, are having with your clients really is something that is important. And quite frankly, any provider of a GLP-1 needs to be aware of those plan dynamics to best serve the patient population, which we'll talk about in a second. The third component here is around concerns around clinical and best practice. So generally speaking, providing access to a treatment needs to be clinically appropriate when it comes to FDA approval, when it comes to that physician best clinical judgment, when it comes to the patient's plan design, and when it comes to the patient's individual environment. So we see a lot of risk in partnering with a program that's sort of going to blanketly offer GLP-1s without considering the holistic impact of pharmacological therapy, which should be the case for any drug. So our holistic approach to weight loss, if you flip to the next slide, is really around multidisciplinary support. So when we think about helping a patient go through this process, it is a relationship not just with a primary care physician who is and should be the center of a weight loss journey unless the patient is comorbid enough, but it's also interventions from dietitians, mental health counselors, therapists, and behavioral health coaches. And that team approach has been proven over and over and over again to be more successful than a single provider stream alone. The second is the power of virtual coaching. So there's a lot of kind of commentary around the value of in-person versus virtual weight loss clinics. There is a lot of evidence that shows that virtual nutrition coaching and behavioral health coaching around weight loss is actually more impactful than in person simply because the barrier to access and the level of utilization is different. Virtual care is easier. It is also more frequently used. And the number one most important thing about a weight loss journey is routine touch points and accountability with your provider. And that is very impossible to get when you have to go in person every single week. And then lastly, as I've already mentioned, delivering care in the context of the plan. So let's take some time to describe what our program looks like. If you go to the next slide. There's really 4 components to our weight loss program. The first is just simply appropriately identifying the patient and helping them get access to the program. So a lot of our patients will self-refer. They'll raise their hand and they'll say, I want help losing weight, or I've been told that I need to lose weight, or this is something that I'm curious about, and they'll raise their hand and ask for help. Some of them might be identified through on-site biometrics that we are providing. We are on those on-site biometrics looking at BMI, abdominal circumference, as well as a host of blood draw or finger prick data, such as A1C, glucose levels, cholesterol, etc. And that confluence of data leads us to be able to pretty accurately predict the true risk of what the weight loss situation is. BMI alone is very rarely enough. And then lastly, provider recommendation. So we do have some patients who come to us on the urgent care side or the primary care side or the mental health side, and weight loss isn't even a thing that they're thinking about. But when they're educated with the provider who's had the right data, sometimes it's made available to them this idea that this could be a path that they should choose. So some of it's proactive from us. When a patient's in our weight loss program, it's a combination of a relationship with our primary care as well as with weight loss coaching. So from a medication management perspective, actually, if you'll flip to the last slide, we are doing prescription-based modeling. So what one slide before is what I meant. We're working through if and when pharmacological therapy is relevant. So sometimes that is a GLP-1. If that is a GLP-1, we are looking at FDA guidelines for clinical appropriateness, coverage requirements, what those prior authorizations and step therapy says, and what the clinical recommendation of the provider is. What I want you to take away here is that we are working very intricately with the existing structure that you have created. So if you need patients to have 6 weight loss coaching visits before you will cover a GLP-1, we can be that weight loss coaching environment, and we can also be the entity that helps the patient report out on the coverage so that they can get it covered. We are also looking at non-GLP-1 medications that have supported weight loss for 10s, 20s of years. So there are a couple of medications, specifically when it comes to comorbid conditions like metformin and Topamax, which have been proven to support this same journey in different clinical environments. And it would be ignorant of us not to consider those as equally important as the GLP-1 prescription. We're also working through steerage and navigation. I've kind of alluded to some of that in terms of how we're working with the pharmacy plan design, but we're also doing that when it comes to services that we don't provide. So we are working with patients who may be severe enough that they are a good fit for bariatric surgery if it's covered. We may be working with patients that are severe enough that they need in-person relationships with an endocrinologist in addition to working with us. And so having the ability to find high quality, low cost care outside of our virtual environment is pretty important. On the weight loss coaching side, which now we can move forward, we are helping patients work with behavioral health coaches and registered dietitians, nutritionists, and where needed, personal trainers to support this entire journey. And I cannot tell you enough how important this is to the weight loss journey. On average, when patients engage in our weight loss coaching, they lose 12 pounds, which means that we are impactful even without pharmacological therapy, without medications. The way that this works is patients come to us, they set some cadences for how to meet with their coach who is trained in behavior change. They set long-term, short-term goals, micro goals, and they have regular accountability check-ins. But more importantly than that, we are addressing the underlying causes or root of weight gain. So much of a person's relationship with their weight is cultural. It's psychological. it's resource dependent. And if we don't ask the questions about stress or work-life balance or sleep habits and move boulders out of the way, that patient, no matter how much medication they take, will always be in this state of weight loss issue, especially after they go on the medication or go off it rather. So this weight loss coaching is really the primary resource coupled with navigation and medication therapy that leads to change. And if you look at any in-person weight loss clinic, this is really the crux of the work that they do with these highly qualified physicians and ancillary support providers. So to take this kind of a step further and to look at a story of impact, I do want to share a story of a patient who engaged in our weight loss coaching. We had a 51-year-old male who came to us with a BMI of 57, a very large abdominal circumference, a weight of 378, technically morbidly obese, A1C of 6.9. So we had some comorbidities happening, specifically as it pertains to diabetes, also suffering from sleep apnea, and then unsurprisingly hypertension. We were assessing this patient's readiness or barriers to change, and also this patient's goals. So after an initial health screening, we recognized that this patient sort of had the financial dynamics that permitted him to make a change. He had the right support system at home, but he was lacking a lot of confidence or motivation because he had some psychological barriers. So we actually helped him partner with one of our therapists who specializes in someone dealing with an eating disorder or weight loss, weight gain journey, as well as the dietitian who helped him identify some very clear areas where he was struggling and where he needed to improve. After a year with him, he lost 70 pounds. His A1C dropped to 5.6. We had many, many, many sessions with this patient, ongoingly, sometimes weekly with this patient, as his basically best friend in the weight loss journey. And his payment to us was $0, because this is a capitated program and our patients pay nothing when they engage with us. And the kind of broader overview commentary I'll make here is ease of use and feelings of safety and truly applying psychological principles towards weight loss, in addition to recognizing the genetic or sort of biological component of weight, is the only way to truly address this problem. So my ask for you as you kind of go back and talk with your clients or with your consultants about this is to think through what your approach to weight loss is and how you think about serving these patients, giving them best access to clinical medication when necessary, but within the realm of health and within the realm of long-term support. That is kind of our perspective on it. And if you ever want to talk about a client in particular or about your population, I'm happy to jump on the phone and explain how we might be a good fit for you in this journey. So thank you all for the time. I appreciate it. And I hope you have a wonderful rest of your day.
Rena, as always, thank you so much for a wonderful, thoughtful presentation, and apologies for mixing up the slides there. Thank you, everybody, for joining us today. We hope to see you at our May Benefits Buzzes, and we also have one at the end of April. Thank you again for your time, and have a wonderful rest of your day.
Bye, everyone.